Good morning, everyone. I'm Olya Kolar. I'm a pediatric nephrologist here at Stanford. Welcome everybody to Grand Rounds, both to our in-person and Zoom audience. Before we begin, I want to recognize that Stanford sits on the ancestral land on the Muwekma Ohlone tribe. A couple of information announcements as well for this attendance and gaining CME credit for these Grand Rounds today. Please use the text code to the left, 44905. And then you can also log into the CME page and claim credit for today's session. Moving forward, today we have a very special session in recognition of Women's History Month, and later on, our Associate Chair of Policy and Community Engagement, Dr. Chamberlain, will introduce our panelists. But I will just remind you for the upcoming Grand Rounds and events in the Department of Pediatrics. On March 31st, we have the also very special Ben Ephraim Family Endowed Lectureship, Pediatric Palliative Care, presented by on accompanying parents and centering the good. Then on April 7th, we have another special lecture with the Mario DiCarlo Memorial Lecture Series in Pediatrics. This will be presented by Edward Barksdale from Rainbow Babies and Children's Hospital on Unbreakable Contract, a new paradigm for academic surgery. Additional announcements, just to bring your attention to our upcoming 14th Annual Pediatric Research Retreat that will happen on April 20th here on campus. Just a brief look at the day. There will be various sessions. Initially, we'll have speakers present on different topics, and then there will be lunch and roundtables where you can meet with different offices of Department of Pediatrics based on your interest and network with any questions you may have in careers Department of Pediatrics. And then this will be followed by another session of talks, and then a poster session and reception at the end of the day. So please welcome to Pediatric Research Retreat in April. Another wonderful symposium coming up is on pregnancy and fetal development with fundamental discovery. This will be on April 21st. And this symposium strives to improve the health of human pregnancy. It is essential to understand the underlying biology of pregnancy, human placental and fetal development. And I will now let Dr. Chamberlain present our panelists today for a very special session in recognition of Women's History Month.
Thank you. Well, it's a very exciting day today and a very exciting panel. Thrilled to be introducing you to our speakers who are going to talk about advancing health equity in research, framework, and practical strategies. So who we have joining us here today, Anisha Patel, who is a professor in general pediatrics. We have Dr. Ananta Addala, who's an assistant professor in pediatric endocrinology. After that, we have Dr. Patricia Rodriguez Espinosa, who is an instructor in epidemiology and population health. Continuing to work our way down the panel here, we have Dr. Bonnie Halpern-Felsher, who's the Marron and Mary Elizabeth Kendrick Professor in Pediatrics in the Division of Adolescent Medicine. And very excited today, please join me in welcoming a high school student who is on the Reach Lab Youth Advisory Board, and her name is Anagha Dogiparthi, and we're very excited to have her voice join this discussion this morning. So please join me in welcoming our wonderful panel, and we look forward to your questions.
Thank you so much, Lisa, for that warm welcome. Hello, everyone. Good morning. So today we're very excited, as Dr. Chamberlain mentioned, to really talk about how we can advance health equity in research here at Stanford and what are some of the frameworks and strategies for doing that. So the learning objectives for this session are, first, we're going to describe why health equity in research is important. We're going to highlight how using a community-engaged approach helps to advance health equity. And lastly, we're going to communicate. You will hopefully be able to communicate at least one practical strategy for advancing health equity in research. So to give you a quick overview of what our panelists are going to cover. So right now I'm going to give you just a quick introduction and lay some ground rules in terms of definitions. That will be followed by Ananta Addala giving us an overview of why it's important to increase diversity, equity, and inclusion in research. Next will be followed by Dr. Patricia Rodriguez Espinosa talking about ways to evaluate community engagement efforts to promote health equity in research. And that, not last but not least, we're so excited to have Dr. Bonnie Halpern-Felsher, but also Anagha Dogiparthi really talking about her experiences using community-based participatory research and youth participatory action research and giving some examples from their own work. And we hope to spend about 15 to 20 minutes at the end, really being able to get questions from the audience here as well as on Zoom. And we also have some questions planned in case there aren't sufficient number. So, and there will be. Lisa's looking at me like, yes, there will be. So really just to kind of set the groundwork here, what do we mean when we talk about health equity? How many of you have seen a figure like this before? Has anyone seen this particular figure recently? This is the latest version, I think, that's come out from the Robert Wood Johnson Foundation. And I saw it and I really liked it. But health equity is really this concept that everyone has a fair and just opportunity to attain the highest level of health. And I think this is depicted here in this slide in terms of equality being that everyone gets the same, regardless of what's needed or right for them. But equity is really that when everyone gets what they need based on their barriers, their circumstances, and their conditions. And I think this really rings true for a lot of us in the clinical setting here at Stanford in our outlying communities. So when we think about this terminology of community engaged research, how many of you feel like you have a good understanding of what we mean when we talk about this? Because it's been thrown out a lot lately. I think it's kind of a buzzword that's come up, and I feel like maybe we don't do a great job of defining it. But community engaged research is really a spectrum, and it involves like engaging community in any of the research process. So at very minimum, I think here at Stanford, we could think about when we have participants in a study, how can we at the end of the study make sure that they receive the results at least, and not just the peer-reviewed publication that sits in PubMed and half the time, you know, our patients can't access anyway, but really thinking about how can we like put together an infographic or some kind of visual to help depict the results in a way that our patients can understand. How many of you have actually used some kind of infographic or other tool to kind of communicate to your families about the work that you're doing? Great. So I think that's kind of the minimum. And then on the very far right end, you see community-based participatory research. And that is research that is really undertaken in full partnership with the community. And I'm going to give you a definition of that right now. So this is Barbara Israel. She's a guru in community engaged research, community-based participatory research, along with Nina Wallerstein, who was here at the MSHS symposium recently. And this definition suggests that this is partnered research approach that equitably involves community members, organizational representatives, and academic researchers in all aspects of the research process. It enables all partners to contribute their expertise and shared responsibility and ownership for the project, and also integrates knowledge with action. And I think that's really key, because I think in a lot of our work, we found that patients and community members really want us not only to describe the disparities, but also create solutions to address them through interventions, policies, or practices. So when we talk about community, I think this also is kind of a misunderstanding, you know, when we talk about community engaged research, thinking that it's just like a community-based organization, and actually community engaged research encompasses all these individuals. So it really is up to you as the researcher or the clinician to think about who is your community that you're wanting to work with and develop solutions for, whether it's medical education or research. And here you can see it can be your patients, it could be your health professionals if you're thinking about provider guidelines, it could be the hospital system or the community-based organizations or schools that are serving the children that we serve. So with that, I'm going to lead off, and Ananta Addala is going to come here and talk about diversity, equity, and inclusion in research, and that will be followed by our subsequent panelists. Thank you all.
Thank you very much, Anisha. And I usually try not to bury the lead when I'm talking, and so the lead is right there, which is that trials should be as diverse as people who are at risk for the disease. And that is really the goal of why we're talking about diversity, equity, and inclusion in research specifically. This is an infographic or sort of pictorial depiction that's adapted from the Institute of Medicine a whopping 21 years ago. It does not feel like 2002 is that long ago, but maybe it does for some of you in the room. And what I've done here is I've adapted what used to be historically discussed as disparities or differences in healthcare delivery to say differences in research participation. Now, we know that there's a difference in non-minority versus minoritized individuals in how much they participate in research. And the Institute of Medicine has said that there is really a difference, and that difference is different than a disparity. And so they say that the difference really comes from whether the youth or the family prefers to participate in clinical research or whether it's appropriate for them to engage in that clinical trial. The other is also the infrastructure of research, and I'll discuss what I mean by that, but it's really who are the researchers and who are the research staff. And then the last is this discrimination, stereotyping, biases, assuming that a family is or is not ready for research. And they say that the disparity really sits in that lower half, which is the infrastructure of research, who's asking the questions, and then discrimination, but that youth and family preferences is not part of the disparity. And my argument always is that there is a lot of structural things that have been in place historically that really says, absolutely, families have their own say in whether they participate or not, but to not acknowledge the system level differences and the historical advantage that people have taken of minoritized families wouldn't be appropriate in thinking about how youth and family preference plays in. So why prioritize it? And I think the first is I usually take a Aristotle type approach to why you should change what you do. And the first is the authority says so. And so the authority for us, generally speaking, our governing body is the AAP, and it's identified racism as a core social determinant of health and also in sort of research participation. The second is that Aristotle says why we change is the emotional aspect. So it is the right thing to do. I think especially over the last 3 years, it's been glaringly obvious how differently and disproportionately our minoritized families are affected. And so it is really getting individuals into clinical research. It's important, coming back to that initial tweet from the NIH that I said. And then the third reason to change is just the logic of it, which is that most of us who are interested in understanding and undertaking scholarship are interested in doing the right thing. And I am obviously a pediatrician, like most of us here, and I have this picture of a heart attack, which I know most of us don't think about, but it's actually one of the most classic examples of when we're introduced to a difference, an artificial difference in clinical outcomes simply because of who was researched first. So because a lot of heart attacks were initially researched in non-Hispanic white males, there's a classic symptomatology that people think when they think MI, and that is just not population representative. And that resulted in this artificial classification of typical versus atypical MI that still persists to date. And had we had a more heterogeneous and population disease representative cohort from the beginning, we would have been behind the 8 ball for minoritized individuals and women who have a different